And now you can go.
So good morning, everyone, and thank you so much for coming. So my name is Nazliah Azzahra, and today I will be presenting my thesis with the vital impact of renal function on iodine-131 biological half-life in thyroid cancer patients. First of all, I would like to thank my supervisor for all of the support, guidance, and the time that helped me to go through this journey. And first of all, before we start, I would like to explain that initially my project title is Understanding Iodine 131 Retention and Clearance in Thyroid Cancer Patient. With the aim is to identify what are the predictors of abnormal clearance of iodine. But however, after further discussion with Dr. Das, we decided to narrow and refine the focus into only renal function. And to give a bit overview about the thyroid. So the thyroid is endocrine gland with butterfly shape that is responsible for metabolism and growth overall. It is synthesize three main hormones. The first one is T3, and the second one is thyroxine or T4, that is responsible for digestion overall and brain development. The last one is calcitonin, which is responsible for bone health and kidney clearance rate. And when we are talking about thyroid dysfunction, there are two main types of thyroid dysfunction. The first one is thyroid disease, and the second one is thyroid cancer. And there are two main categories for thyroid disease. The first one is hyperthyroid, where the thyroid produces too much hormone, and the second one is hypo, which is the thyroid gland doesn't produce enough hormone. And in terms of thyroid cancer, there are five different types of thyroid cancer. The first one is papillary, follicular, medullary, differentiated carcinoma, and the last one is anaplastic. But only the first two categories, which is papillary and follicular, that is responsive to iodine treatment. That's why in this thesis, I will only be focused on the first two categories. And usually when someone is diagnosed with thyroid cancer, they will go through three main steps of treatment. The first one is thyroidectomy, which is surgery to remove the thyroid gland, and then the patient will go to radioactive treatment, and then last one, and then finally, patients are given synthetic thyroid hormone to replace the hormone that the body cannot produce anymore. Before the active therapy, usually we have to elevate the thyroid stimulating hormone or TSH level, so that the body will think that it is in low of thyroid hormone. And this is usually being done by two different methods. The first one is stopping thyroid hormone pills for about 2 to 6 weeks, and the second one is injecting synthesis thyroid stimulating hormone. And iodine usually given orally in form of sodium iodide, and once ingested in the body, it will be taken up by the thyroid cells, and it will emit beta particle to kill the cancer cell. Once ingested, the iodine will go through 4 different steps inside the human body. The first one is will dissolve in stomach, and then it will absorb in small intestine and enters the bloodstream to be then taken up by the thyroid gland, or any metastases or any tissue that's expressing the sodium iodide is important. And finally, the unused iodine will be cleared from the kidney, from the body by the kidney, and each of these steps can be affected by the patient organ function. So, for example, if the patient has like GI disease like celiac or any gluten intolerance, it will reduce the absorption, and also the drug consumption, yeah, is also will be affected. How the blood will distribute the iodine, and sorry, and finally the excretion step depends mostly on the kidney function. And this thesis will only focus specifically on the fourth step, which is the kidney function. There are two common parameters to describe the kidney function. First one is creatinine. This is our muscle waste product. Basically, the kidney should excrete or clear the creatinine, but if the creatinine level inside the body is high, means the kidney didn't function properly. But there are downside of this parameter because this is a muscle related product, so it strongly depends on the muscle one. So people with more muscle, more muscular, or consuming creatinine supplement may have higher creatinine level. The second parameter is estimated glomerular filtration rate, or eGFR. Basically, this measures how well or how fast the kidney filtering the blood. And eGFR are usually obtained using the formula like on the screen. It's calculated using a formula that consider age, sex, and ethnicity. And normal value normal value for eGFR is above 90, and when eGFR drops below this, this is indicate that the kidney may be impaired or the kidney may be damaged. And because the kidney are the main organ for iodine excretion, the hypothesis here is lower eGFR will slow down the iodine clearance, and then it can lead to longer biological half-life and a higher radiation exposure. So that's why the aim of this study is to examine the relationship between renal function and iodine half-life, specifically biological, in cancer patient, to propose dose adjustment based on patient eGFR. There are two questions that need to be answered. The first one is what is the quantitative relationship with eGFR and biological half-life, and the second question is if the patient has eGFR equals to X, for example, how should the prescribed iodine dose be adjusted so that the exposure is comparable to patient with normal kidney function. And to address the questions, I conducted a systematic review and meta-analysis without any restriction with on publication date. It was performed using those database, and the search strategy was built by 4 categories. So within each categories, I combine using OR operator and the 4 categories were linked using AND operators. And also this protocol and systematic review overall was already registered in PostGR. Finally, this is the result paper. So initially there are 39 papers that I got, and after removing duplicates and full text screening, 13 studies were included. And all of the others were conducted to ask for anonymized patient data, for example, like half-life, age, sex, or creatinine, prescribe those, but yeah, no one replies. But we were so lucky because there are 4 papers that has a graph. So the graph is eGFR versus effective half-life of iodine. So all of the graph were digitized for the meta-analysis and dose adjustment using software called plot digitizer. And the remaining 9 were included in the study qualitative. So these are the summary of the papers. The studies included published between 2009 and in 2006 and 2025 with the patient with only PTC and FTC patient who underwent radioiodine-131 therapy. And across all of this, there are 4 prospective study and 9 retrospective study, and across all of this study, there was a clear female dominance for typically around 2 to 3 times more than male patient. The mean age from all of the study is ranging from 30 to 70, and except one study that is focused on children and adolescents, which is the 12 study by Wayne et al. And when we are looking at the kidney parameter function, which is creatinine and eGFR, 7 out of 7 study reported that there is significant effect on eGFR on half-life, but for serum creatinine, there are 2 studies that report not significant relationship, and one of these is again study by Wing et al. The reason for this is the age. So because the entire population is under 18, so the creatinine level in children usually reflects the muscle mass, not the how well their renal clearance. Oh, sorry. I have to mention that the study highlighted in red is the study that is selected for further analysis for the dose adjustment. From those 4 studies, individual eGFR and effective half-life data was obtained. And the effective half-life was converted to biological half-life using the relationship on the screen. After that, the data analyzed to calculate the correlation and how significant, and also for the regression model and dose adjustment. The data then plotted for each different study. X-axis is eGFR and Y-axis is biological half-life. There are in total 297 patients. And to make the differences clearer, here is the graph showing the relationship between eGFR and biological half-life for normal kidney function, which is the blue dot, and impaired kidney function on the red dots. And as you can see, the curve on the left side, the blue red dots is much steeper than the graph on the right side, which indicates that the patient with lower eGFR tend to have longer biological health. And also this table summarize the statistical analysis. It shows that eGFR is significantly contributed to the variance of biological half-life, and from the R and also P value from all patients. It is we can say that there's a significant negative correlation between eGFR and biological half-life. But however, if we look at the last two groups, the third and the fourth groups, it shows no statistical significance. My assumption here is the third group, 45 to 60. The kidney function may be too damaged or too impaired. So we cannot predict how the kidney will behave. And for the lowest group, their sample size was too small to draw any reliable conclusion. And to be able to understand the relationship mathematically, I modeled a fitting curve using all of the data. The red curve over here. The red curve over here represents the best fit line that is described by half-life equals to 611 times eGFR to the power of minus 0.856. This can be seen on the top left. I got the value of R squared equal to 0.456. And the slope is minus 1.558, which means there is 1.56 hours increase if the eGFR decrease in 1 unit. But what is much more important here is the relationship is not linear. So for example, 10 unit decrease from 90 to 60 in eGFR will prolong the biological half-life by 1.56. But if we go from if the eGFR drop from 60 to 50, it will prolong the biological half-life by 2.6 hours. And this can also be seen clearly in this table. This is the table that compare the biological half-life from each groups to the normal patient. So the first GFR level, the difference is around 5 to 11 hours. But as kidney function decreases, the gap becomes much longer. So, and in the last group, you can see that the difference can reach up to 27 hours. Finally, we reached the dose adjustment model. So the fundamental goal of this is we want the patient with renal impairment or kidney damage deliver the same total body exposure, which is characterized by area under curve, as with patient with normal renal function. And mathematically, the AUC is directly proportional to the administered activity. And for a patient with reduced renal clearance, if the administered dose remains unchanged, it will increase the area under curve beyond what we want. So if the half-life increases due to reduced clearance, the administered dose should be lowered to keep the total exposure or to keep the AUC the same. And we arranging this equation, we have the equation over here, which dose patient is dose is prescribed to the people with abnormal renal function, and the normal is the effective half-life for patient with renal function, and also the half of patient is the effective half for a specific patient with eGFR lower than 90. After modeling the data, we obtain a mathematical regression model to adjust the dose. we can see the equation on the top left again. And for the matrix, we got R equals to 0.8185. Is pretty low, but the root mean square error and mean average error is around 0.6 and 0.7, which means the average error of the prediction is quite small. So even though the R is quite small, the model still give a fairly good prediction. And I think this is makes sense because eGFR is not an important. eGFR is an important factor, but it's not the only thing that affects iodine clearance. And after some normalization, on the left, we can see this is the dose adjustment curve that has been normalized, and on the right side, this is the proposed dose adjustment based on each eGFR range. So, for example, in here, patients with eGFR around 60 and 80, 80 something, we can adjust the dose up to 75%. Before closing, I would like to highlight a few important limitations of this study. The first one is limitation of individual actual data. Most of the study didn't include any raw data and the data, which restrict how precise my analysis. And second one is because of the lack of the data, the model tend to oversimplify. The third one is limited data for severe kidney function. Finally, the model needs to be validated because this is just a theoretical model. To build on this work, first, we can do any prospective clinical trial to validate the dosing adjustment algorithm, and also develop integrate dosimetry to the factor other than eGFR, for example, thesis method for any metastasis or paraglobulin level and etc. And maybe develop some AI to predict how we should give those to the patient. The last one is to explore better biomarkers like cysteine C for estimating the eGFR rather than only creatinine. Conclusion to conclude, we have established a clear inverse relationship between eGFR and the biological half-life, which we quantify using this relationship. The most important one is this effect is not linear. And finally, to address this issue, we develop a dose adjustment formula, which allows us to individualize dosing based on the kidney function. To close, I remember I presented two of this graph on one of the weekly meeting, and now the graph has been filled and meaningful. And thank you so much for all of the people that has been helping me to fill the graph. And this is, oh yeah, that is some of the reference that I used. Thank you.
Thanks, Nazliah. Great work. Are there any questions? John, go. I may have missed it in the calculation of the eGFR, but what's the patient factor that goes into calculating that, not just the sex of the patient?
Sorry, Julian. Let me. Do you mean this formula? Like,
Yeah, so it's the creatinine levels that calculate that.
yeah, it comes for the creatinine level, age, sex, and also ethnicity.
Thank you.
Nice. So if you're adjusting the dose for the toxicity in the kidney, at some point the treatment will become ineffective in the thyroid patient. What is the threshold for having an effective thyroid treatment?
Like, I just want to confirm, like, do you mean the dose, the minimal dose to ablate the remaining thyroid tissue? I haven't looked at it at this stage, but from what I remember, usually if the dose to the thyroid already exceeding 2 grams, if I'm not mistaken, then I can say that the ablation is successful.
It's probably the same dose, although we reduce the dose. Because there's no relief of iodine in the body, iodine stay in the body and keep absorbing.
Right.
So the dose in the thyroid is the same. That's the treatment is not going to be affected. Less toxicity to the patient because they were assumed patients, release of iodine is normal, but it's not normal. We keep accumulating the iodine, we keep absorbing, reach to the level. The rest is going to be toxic, so minerals and especially digestion system. But as you question, it's going to be the same treatment. Less dose, but absolutely the same. Less injection dose, but absolutely the same.
My question follows on from that. It's do you think that there are any other factors that would affect the clearance of iodine and the absorbed dose, like, for example, how much it's taken up into the thyroid?
Yes, absolutely. From what I have read, the clearance is affected by eGFR first and metastasis, like how much the metastasis inside the body, and also I think that's all.
So do you think it would be worth including those into a future model?
So we can make the model become more precise. That will include all of the parameters inside the patient.
Are there any other questions? A few.
Yes,
No.
please go ahead.
So yeah, I just wanted to quickly, if you go back to slide 13, it doesn't appear that the numbers add up
Yeah.
here.
Yeah, I just realized it from your email, and I don't have time to change the number.
Okay,
on that.
sure. So yeah, 36 minus 9 is a
It should be.
29. Yeah.
It's
Yeah, and maybe just if you could clarify on slide 19, you mentioned that there wasn't a statistically significant result for the correlation for the last two categories. But I wasn't really sure why you thought that was.
So one of the limitations of this statistical analysis is we don't have the actual patient data. So at this stage, I cannot say clearly why is this happening, but from my assumption and from what I've read, the third one, two, three, yeah, the third group is the kidney only function like half of the function itself. So it's already to be damaged to be able to like have like what other person kidney behave.
Thank you. Thanks, Nazliah. Good work.
So would you like to switch to Nazliah?
I'm fine with thinking.
Smart. Go ahead.
I'll switch if you want.
Oh, Max is not sure. Which one is not power? So any either of those?
Any is fine.
What's going on?
So we should